Versus surface procedures in refractive surgery. So the basic thing is to weigh the subtleties of doing LASIK, which is a flap-based procedure, or any flap-based procedure, versus a surface ablation, where you preserve more of the cornea and do it exactly on the epithelium. So now, what we mean by a flap-based procedure is that we take either a keratome or femtosecond-based flap. So here you can see the mechanical keratome that has raised the flap first, followed by the femtosecond laser. So depending on what is being used, the smoothness of the elevation could be different, and the way the meniscus is formed could be different. Then this followed by application of the laser, excimer laser, to the stromal bed, followed by repositioning of the flap. So now you have a covered area over which, over the excimer ablation. Now, on the other hand, trans-PRK, which is what is followed now more than PRK, is where the ablation is done on the surface. It's the laser itself that removes the epithelium and then carries out the excimer ablation. So, because of the flap, the patient discomfort is much lesser. It lasts for a couple of hours till the epithelium on the margin of the flap heals and blends with the rest of the cornea. A wide range of power can be correctable in the normal cornea. Pre-op workup is crucial for both procedures, especially in LASIK, where you're going slightly deeper than trans-PRK. Now, these are some of the complications that can happen in LASIK. So, you see that here a keratome has been placed. So, and as it runs, so whenever there's a flap, there are likely to be complications associated with the flap. So that is the basis for most complications in LASIK, especially with novice surgeons. And you see, as the keratome run gets over, there is a split in the flap. So this is a dehiscence right there in the flap. You have a smaller portion there and a larger portion on the other side. And then this cut that passes through approximately 1/3 of the flap. So once it heals, you'll see there that there is a small scar. If it's in the visual axis, it would be extremely disturbing to the patient. Now, in small eyes, especially when you have very contracted sockets and the patients are not able to open their eyes much, the keratome may stop midway. It doesn't complete its full run, and you can have a hinge prematurely, like you see over there, a large, long hinge. Plus, if there is undulatory movements of the blade, you can get something like buttonholing that may not be through and through, but can cause elevation in the stroma. So these are sources of aberrations, basically. So what we do for that is open the eye very well whenever there's an applanation or a motor needs to run in the eye, or pressure needs to be applied, so that the movement of the keratome is free. The ring should also be placed very well inside the speculum. Now, this is what happens when you have done the procedure, repositioned the flap, and then as you're taking out the speculum, there could be slight movement of the flap. So you need to float the flap again and then put it back and then dry the surface as usual. Now, what happens if the same thing happens after a day is that more epithelium grows on the surface and it tries to, smoothen out the surface. So you can see these folds that are getting adherent to each other, and you need to, rupture the epithelium to just straighten them out. You'll also note that as you go to the periphery, and you lift the flap, the area between the edge of the flap and the rest of the stroma, cornea, is also covered by epithelium. So it's epithelium that's trying to, mend things over there, making it much smoother. And that's why it's harder to float the flap. And another thing is that you'll get a lot of striae on the flap. And those are daunting, for which you actually need to peel the epithelium off from the top of the flap before you repose it completely. So this is what's being done over there. You can see that the epithelium is being removed so that you can smoothen out the flap much better. There may be a few folds left when you're completing the procedure, but on the next day, it comes out to be very smooth. Epithelial ingrowth is another factor that can happen with LASIK because of the presence of the flap. Then another thing is the ablation. the slight incompleteness of the ablation if the hinge corresponds to the axis of the cylinder, which can happen with keratomes that take flaps only in a particular direction. There are keratomes that take only in the superior direction. There are those that take only in the nasal directions, but those that can be rotated, like you see over here, the Moria M2. Here, when the ablation falls on the hinge, then there is ablation of both the hinge and the stroma adjacent to it. Because of which, when the flap is reposited, there would be a small depression in that region. In the periphery, it doesn't make much of a difference. But if the hinge is premature as well, then that's when it compounds the problem. So for an ablation at around 40 degrees, it would be wiser to take the hinge at 110. And likewise, depending on the orientation of the cylinder, you can move the hinge around. Now here is an opaque bubble layer that can happen with a femtosecond LASIK. This can usually happen if the energy is on the higher side, or if you are using a thinner flap, especially with 90 micron flaps. I had done a study where with 90 micron flaps, we found that the OBL is much higher. So it goes off in a bit, but sometimes it could produce small pillars of tissue between the stroma and the flap, because of which elevation of the flap becomes a bit of problem. Sometimes eye tracking may be a problem. The amount of laser, the fluence of the laser when it reaches the bed may not be actually what shows up on the screen. So all these are small problems that may be associated with it. Another factor is air in the anterior chamber that can happen. Again, in femtosecond laser, it's not very common, but sometimes air can pass through the trabecular meshwork and enter the pupillary area. So that doesn't do much of a problem, other than it may affect eye tracking a bit. So you need to let the patient sit for maybe an hour or so till it clears up, and then take them back again. Now, if you're able to track through and through, it's good. You can switch off the tracker off as well, but not recommended. Now, coming to the second procedure. Now, there's not much to show over there because you're just ablating straight on and then coming out. So the chances of complications because you're not touching the eye is much, much less. So now what is there in the back of any surgeon's mind is patient discomfort and chances of fibrosis, which is virtually nil when you're using mitomycin for the recommended amount of time. And with all the advanced lasers now these are the lasers, there's the Alcon map with its trans-PRK. So earlier the lasers used to create a more hyperopic correction at the periphery compared to the center. So now that's not so, because the blending is much more smoother, the spots are placed close together, and they're not large diameter spots. The epithelial healing is also relatively fast, because of which the patient discomfort is less. And one reason for that is that the edge of the epithelium is defined by the laser and therefore very, very smooth. So this is an advantage in thin cornea, dry eyes for higher corrections. And the last two are the most important in professions where you cannot afford to have a flap or a flap displacement, and for retreatments. So whenever you're treating, whether it's smile or whether it's post-LASIK, or doing on the surface is a much better option. So compared to olden days, the healing is much quicker, and like I mentioned before, it's a much more compact procedure than a long PTK-PRK combo. Ectasia is of importance in both procedures, but then, like Santon earlier mentioned, it depends on the pre-op workup more.